think now we can go ahead and take the case. I think we are starting with Dr. Hitin. Dr. Hitin has a case on Hallux valgus.
Yeah.
Could you make
Yes.
the presentation? Yes, Hitin, go ahead. As this thing, so today we were having,
I'll make it.
because two of our speakers
Yeah,
are not there,
start,
so
sir.
we are just, yeah, go ahead.
Okay, so this is the case of Hallux valgus, one of Ajoy's cases. So this is a 22-year-old male with a bilateral deformity, which is painful. It was flexible to begin with. So any of the panelists or the faculty want to comment on what we want to do, how they would proceed? Or should I go ahead?
Yeah, I think so. You can go ahead. I think when it comes to some more discussion.
Yeah, Hitan,
Okay.
quickly tell us what did you
Procedures
do?
chosen, yeah.
How did you assess this first?
So the examination of the foot was done, as I mentioned in my talk, both from proximal to distal, as well as I saw whether there was a Achilles tightness or a flat foot. So none of them was there in this. But the deformity was flexible in the sense I could reduce the intermetatarsal angles and the hallux valgus with pressure. Anything else you want to know?
Why was it? Is it painful because of pain over the bunion side or pain?
So there was pain on the bunion and the medial eminence. No pain over the plantar aspect of the foot.
Okay. Any corresponding pathology like flat foot, pes planus valgus, or any?
No. As I said, no flat foot, no calf tightness.
Fine, go ahead.
Go ahead.
Okay.
Yeah.
One question.
Right, so this is
any history of metatarsalgia transverse?
No, there was no pain over the undersurface of the foot, no pain on the plantar aspect, no bunions on the, no calluses on the undersurface, so no incidence of plantar.
Okay, thank you.
Heredity?
No, not hereditary. Not hereditary. No, she is the only one in the family to have this.
Okay. I mean, parents. Okay.
Go on, Hitan.
Should I go ahead?
Yes.
Yes.
Okay. So this is the AP X-ray of the foot. Okay. So anybody else wants any other X-ray views, or this is okay?
So you would want a lateral weight bearing as well, just to confirm the findings on
or a CT.
Why would you need a
Okay.
CT?
So what would you want to see on?
Well, I think the overall alignment to confirm the findings that there's no planovalgus, to look for any secondary toe deformity, and see the weight bearing part, and so mainly to look at the overall foot alignment and any secondary toe deformity. That will be clear on the lateral weight bearing X-ray. You can do if you have like midfoot pain along with these things, then you want to explore this further, maybe with a CT.
Okay, so this is the.
I think so. We should go ahead and discuss the angles.
Yeah.
Dr. Hitin, can we just proceed further?
Yeah, I think shouldn't give so many stops, otherwise it'll stretch too long.
We'll proceed further. I think we have drawn all the angles.
Go on,
and all.
Hitin, without asking so much, at every X-ray.
Okay.
Please go ahead.
So that was the AP X-rays. The lateral
so this
X-rays
is the
were also taken.
Right.
Yes. Okay.
So this is the lateral X-rays. There was no, on the lateral X-ray, there was no sagittal. So the surgical planning was based on the congruence of the first MTP of the joint, instability of whether there was any instability of the first TMT or naviculocuneiform, and the severity of the deformity based on the 5 angles that I mentioned on my talk. So this is the left foot. There was incongruence of the first MTP of the joint with sesamoid subluxation and hallux valgus angle of 37 and intermetatarsal angle of 20. The DMAA was normal and there was no metatarsus adductus. On the right side, the same incongruent first MTP of the joint, hallux valgus angle of 40, an intermetatarsal angle of 18, and no normal DMMA and no metatarsus adductus. So what procedures should be chosen? The choice was a soft tissue procedure alone, a distal osteotomy, a proximal osteotomy, scarf, Akin, or fusion, and a fusion with joint. So based on the severity of the deformity, the left side, we tried to do a distal soft tissue procedure along with a proximal crescentic osteotomy because it was quite a severe deformity. So we chose a proximal osteotomy. On the right side, again, a distal soft tissue procedure for the incongruence of the joint and a scarf on the right side.
So may I just interrupt? Sorry, can I just interrupt now?
Yeah.
With the decision.
Yes,
why not do on the left side do a scarf as well? Because
so
you are going to do on the right side, so why change it?
Okay, so on the left side, if you notice the hallux, the intermetatarsal angle was slightly more than on the right side. So a scarf is basically a metatarsal shaft osteotomy, and a proximal osteotomy will help to correct the intermetatarsal angle better. So that's why proximal osteotomy was.
If you look on your algorithm for mild, moderate, severe in your previous algorithm, in all the three, you could easily do a scarf. And I think most of the people would agree that with the 20 degree of IMA, you could probably, if you're doing scarf on the left, right, you could have done on the left as well.
So
that's my thought.
Could have done a scarf also on the left side, but this was what was chosen.
Yeah,
okay,
possibly yes, it's possible to do it, but then both are equally good. I think for this kind of.
My question is, if I can butt in just one point.
Yeah.
Why would you insist on doing the same thing on the both sides, Pradeep? Is there any added advantage? It's a good thing that the two different kind of procedure with similar results are being done, so that they can also have a comparative study of the two procedures.
Are you trying to do a study, or are you trying to give the better results for the patient?
Not actually study, but
no,
I mean
the reason my point is not that. My point is, Hitin looks like he is very comfortable doing scarf. If you're comfortable doing a scarf and you can correct an 18 degree angle of IMA, which comes into severe, you could easily do a 20 degree correction with a scarf as well. If you look at the scarf, the whole history, the key thing of people don't do it is because of the high learning curve and so much of variation you can do it. But if you are really comfortable in doing scarf, which Dr. Mathur is saying, he could easily do it right. And if you're doing it at one procedure, just carry on with that same procedure. That is my philosophy. That's how I see it. But yes, even Ajoy has said you could do easily anything. You could do a proximal crescentic, which of course gives a lot of correction in a large IMA as well. No wrong about it. Don't get me wrong. I'm not saying which procedure is right or which procedure is wrong. What I'm saying is, if you've selected scarf on one side, for the whole sake of the ease of the whole surgeries and everything, I would do scarf on both sides. That's all. Point.
Okay, so my reason for selecting this case was to demonstrate both the procedures to the PG students. So, and to put the message that when you have a severe deformity, both the proximal as well as the shaft osteotomies can be done. So that's why we put on this case.
Let's go ahead, I think.
Okay, go on.
Yes,
sorry.
I think so. Let us proceed.
Right. So this is the image of the patient on the OP table. This is the position of the patient. And this is the left side where we see the incisions on the left side for the proximal osteotomy and the distal incisions for the distal soft tissue procedure and the bunionectomy. And on the right side, the distal soft tissue procedure was done through the same incision which was used for the scarf. So this is just a small video for how to do the scarf. So a longitudinal cut and 2 oblique cuts. Okay. So again, another video. Okay, so this is the scarf being completed and the 2 fragments being separated and translated, and the provisional fixation and the definitive fixation on the right side. The left side, the lateral incision for the release of the lateral structures, the adductor and adductor hallucis and the intermetatarsal ligaments. the medial incision and the incision for the proximal crescentic osteotomy. And this is the fixation.
May I ask, how did you do the?
So the take-home message is, yeah.
Did you use the saw, the special saw which I think AO provides, or you just did freehand?
No, but it was done freehand. Actually, you can do the same thing by drawing, like using small drill bits, like a 2 mm drill bit. If you go ahead and you can just perform like a dome over there. And just that the angle has to be maintained correctly. So if you've seen the Roger Mans, I think you can see the exact
No,
angle
I
in
know,
which
because
to
I
go.
think, Ajoy, you yourself, I remember you had showed that case which you have that crescentic saw. I remember it very clearly. So that's why I thought if Dr. Mathur also used the same thing.
No, the drill bits.
Okay. But are you happy with the slope of the TMD joint post-op?
The TMT joint.
Yeah, the slope of
so this was a young patient's TMT joint was. So there are some studies which show that the slope of the TMT joint is not to be relied on, because it is more of a X-ray picture which decides on the whether there is more slope or less slope. So I don't really look at the slope as per se to decide whether I need to do a fusion or if there is an instability, I look more on the lateral view for plantar gaping and the clinical examination, of course.
Perfect. Yes.
Okay. So the take-home message is clinical and radiological assessment of the deformity should be done. X-rays should be weight-bearing. Surgical decision-making is based on the congruency or arthritis of the first MTPJ and the severity of the deformity. Incongruent first MTPJ joint needs a distal soft tissue procedure along with an osteotomy, and angular measurements help to assess the severity of the deformity and the level of the osteotomy. Thank you.
Great.
Right. So now we'll yeah, this is this flat foot with
Can we just wrap up the cases a little early?
Yes. I'll just play this one. So this is just a flat foot just one case. Are you able to see my screen?
Yes, Ajoy.
Yeah, Ajoy.
Yeah. Okay. Just going on to a slide view. So it's already 1:20. Okay, so just a couple of cases. So this was a patient who had he's about 54-year-old or something. So he is having a Pes Planus on one side. I think there was something which was not touched upon during the talk was the Johnson and Strom's classification. So the type 1, wherein it's a flexible deformity, it's only tibialis posterior tendinitis. The type 2, wherein which is again subclassified into A and a B, wherein in addition we also have some amount of the uncoverage of the navicular which is happening, and in a type 3 where we already have some subtalar arthritis, and a type 4 when we have some ankle arthritis associated with it. So this was a type 2A, and this is the patient who was presenting with this. Incidentally, he also had a Hallux virus. So this was the plan, was to go ahead with doing a medial calcaneal osteotomy. A sliding osteotomy was performed in this case. So that's the lateral incision which is taken, the cut which is made and which is imaged on the X-ray before making the cut, and then this is the tentative fixation, and fixation done by just a simple method of using CC screws. So this becomes, so that is what was being planned. So that's the osteotomy which is performed, and that's how the screws are going to be held and the displacement which has happened in this case. Okay, so we have to look at the medial side also, then look at the tibialis posterior. Very often the tibialis posterior is either quite synovitic or with a lot of degenerative changes which is seen there, just imminent on the rupture. So sometimes it can also be ruptured. So the plan is always to do an FDL transfer. Take the FDL which is just adjacent available there. So use a stitch on that, and through a drill hole through the navicular, we can also always fix it up. And for the Hallux virus, of course, we can do a EHL partial split transfer. So this was just a simple case there, just to demonstrate the presence of a Pes Planus and the performance of a medial calcaneal osteotomy. So with regard to the calcaneal osteotomy itself, So any discussions that could be there with this? Dr. Pradeep, Dr. Kamal, Dr. Maninder?
So, Dr. Ajoy, while you're doing the calcaneal osteotomy, do you always only do a lateral shift, or do you consider taking out a small wedge as well?
A small wedge is not required because we're going to shift the whole thing medially. Just a simple cut there and a complete displacement would be a better thing rather than removing a wedge. A wedge not often is required.
Yeah. Well, yeah, I think I think you're right, basically, because the standard is that once you shifted the Achilles and medially the pull forces, eventually it will stabilize all the valgus forces applying. So, but yeah, if there is something like, even in flexible deformities, if there is a very severe deformity which you think he will still be in valgus after you've not displaced it, and I think that in those cases sometimes we can consider doing a wedge at the same time as well. That's what I
correct. So after taking the Salzman views, I think that's when we can decide on taking a wedge in addition. Okay. Anything more? This was again no. This I'll just escape this. Let's not duplicate the two. One case on foot drop, I think, just to complete the.
While you're pulling it up, I think Arun is asking a question. How do you decide on the medial side procedures? Any criteria, Ajoy?
Medial side procedures for?
I don't know.
Flat foot?
Hallux varus or flat foot?
Flat foot or varus?
Yeah, he hasn't said anything.
Okay, so I'll talk to him personally.
Must be asking for, yeah. That's it.
What's
flat
happening
foot.
now?
Flat foot.
Yeah. Okay. So the presence of the 2A and 2B, I think that is what would make the difference. What is happening? The screen sharing is paused. Okay, I'll share screen again. Visible? Okay, so this okay, so this is a patient who's just a 22-year-old male who had undergone 24-year-old male. So he had just undergone removal of multiple exostosis, some other center. So at the age of around 18, a fibular exostosis, and soon after that he developed a foot drop. And multiple times different locations evaluated, was regularly using an AFO, and he was offered a tendon transfer. So the tendon transfer, I think, that we can plan at this age, at the age of 24, would be essentially be something. Dr. Maninder, the tendon transfer that we would plan would be. Gurnath has already touched upon it.
Basically, he had a foot drop due to the deep peroneal nerve injury.
Yes.
Then that means the muscle from the posterior compartment supplied by the tibial component will be used to substitute the dorsiflexion, which is missing now. So I think tibialis posterior tendon transfer would be ideal in these circumstances.
Perfect, sir. So this is what was planned, and this is what was done in this particular patient. The tibialis posterior isolated from the insertion onto the navicular, pulled up, and this is generally this is a cadaveric video demonstration only, so I'll not play through it here. So this is what was done: taken out the proximal incision to pull out the tibialis posterior, isolated, and then rooted out and into the third metatarsal base. The third metatarsal was identified, and into that base it was inserted, held down by means of just a simple stitch, and was at the end of the patient started doing this, and by the end of almost 3 months he was almost back to walking. He had gained his dorsiflexion. and the small wound on the plantar aspect which had healed up well, and you can see that he was able to walk comfortably. He was off all his orthosis, off his splints, and he was quite happy to be doing this. He was able to demonstrate the dorsiflexion quite well, and this was translating very well into his gait also. But he was unable to perform a eversion very comfortably. So that's about it. Just a simple case again. Not much of discussion. Anything to add on this,
Yeah,
Kamal
I
sir
have.
or Maninder or Pradeep?
Can I add something?
Yes, Dr. Rajiv. Yes,
You said that it's in a case of an exostosis.
yes.
So I have seen sometimes if you want to do the transfers, you come behind the tibia and want to take out the tendon through the interosseous membrane. So
Okay.
in these cases, you have to see. There's another case where you sometimes have a synostosis which is extending quite upwards, and you cannot take out the tendon through that. I personally had one experience. So in these cases,
Okay.
you need to plan yourself that you want to come through the anterior compartment, then coming out through that. So I just wanted to point out that I had a problem in one case where the synostosis was extending quite, and I was trying to do, and then so this is one thing which I learned. So I thought I will share with you guys.
Yes.
The lesson
Perfect.
goes that perform an X-ray of the leg with ankle to see the intraosseous space
Yeah. That is what I
Yes.
wanted to say. You must
to
be
avoid the surprises during surgery.
yeah.
Great,
Right.
great.
Anything you want to add, you can add.
So
Yes.
I just wanted to
Yes.
add this thing. You said the transfer to be done on the base of the third metatarsal. It is also advised that you can do the transfer to the lateral cuneiform because
Uniform
you need
also.
a little longer tendon. You know, the problem sometimes come is getting the right kind of length. So the more you want to go distal, more length you need, and you should always be prepared to do a good fixation with an interference screw because sometimes the length is so small that you can't really pull it through the bone to the plantar side and hold it with a button very well. So these are few extra things which I just like to add, you know.
Right.
Can I add about length problems? Can I add
Yes.
something about the length problems more about that? So basically,
Yes. Go ahead.
there are different procedures which have been used. One of them is a bridle procedure, where you can avoid the length problem. The other is the rerouting technique, where you take the tibialis anterior through the three cuneiforms and take it out of the cuneiform and then do a suturing in the anterior, compartment somewhere. So that is another thing. And of course, one or two things were mentioned in Dr. Guruna's talk, that you can split the tendon as advised by Srinivasan, and you can use this. So these are the options when you have a limited tendon, and use particularly this should be very when you are sometimes doing in compartment syndrome. Can't get them right, so you should be aware of these techniques, that you are likely the conditions where you likely to have a less length of the tibialis posterior tendon, so be prepared for it.
Yeah.
Okay. Okay. I think so. We should be concluding this session now. It's
Okay.
almost 1:30 now. We are almost 20 minutes behind schedule, and
Okay.
we have the master talk coming up.
Uh,
And I would like to thank the panelists who were there, who just pitched in it even at the last moment. Dr. Kamal Dureja, Dr. Maninder Shah, and Dr. Pradeep for pitching in as panelists, and Dr. Hitin for presentation, Dr. Indrajit for the presentation, and for the IFAS for the excellent session opportunity which was given. So let us now carry on with the master talk, sir.
Thank you, Joy. Thank you very much.